Dr. Stevens will present our next speaker.
Good morning. It's our pleasure to welcome Dr. Ralph DeFronzo. He's the chief of the Diabetes Division for UT Health Science Center and the Veterans Hospital. He completed fellowships in both endocrinology and nephrology. And for the past 40 years, he's devoted his career to the understanding and improvement of the clinical care of patients with diabetes. He's had NIH funding for 40 years to cover all aspects of diabetes research to understand the pathophysiology of insulin resistance. He's also led key drug development studies. Whenever we prescribe Metformin, like I did yesterday, we should thank Dr. DeFronzo. He led the studies that ultimately led to the FDA approval of Metformin in the 1990s. Please join me in welcoming Dr. Ralph DeFronzo.
Okay, it's a pleasure to be here. Actually, some new faces. You probably have met up a long time ago, although we are scheming to get some studies underway soon. So hopefully I'll have a lot more interaction with this group. So I'm going to talk about type 2 diabetes, and this actually is a big problem, as you know, since the majority of people entering into transplant programs now actually have type 2 diabetes. And glycemic control in these people are critically important. So we know from a number of studies that diabetes control and complications, a trial of the Wisconsin epidemiologic study of diabetic retinopathy, and a large study from Japan, if your hemoglobin A1C is less than 6, you do not develop either retinopathy or nephropathy. So glycemic control is critically important in preventing the disease. But of course, if you do a renal transplant, then it's even more critically important that you maintain as strict glycemic control as possible. And we also know that if you put all of the blood flow into one kidney, that one kidney is hyperfiltrating. And if you have poor glycemic control in that situation, this actually accelerates the recurrence of diabetic nephropathy. So maintaining really strict glycemic control in transplantation is critically important, and the drugs that we have to use now really give us an opportunity to maintain that level of glycemic control. And you'll see I have particular biases about what I think are the better drugs for treating people with type 2 diabetes, and it will be very clear that I vehemently disagree with the American Diabetes Association approach to the treatment of diabetes. I think it's completely wrong, and it's guaranteed to be met with failure. And because I disagree with what they say, it's the most reason why I have turned down the presidency of the ADA every time they ask me to do it, is I cannot defend the regimen which I know will not work. So what I'd like to do is to take you through our understanding of the physiology of the disease. And I think if you understand what causes the disease, it will be very clear what drugs work and what drugs do not work. Now, the big problem that we have at the Texas Diabetes Institute, we see 10,000 unduplicated diabetic patients per year, is cost. So we know what drugs really work, but for our patients, many of the patients cannot afford the drugs that really work. So oftentimes we get thrown back to Metformin and Sulfonylureas, and these are, in my opinion, not the best drugs for the treatment of people with type 2 diabetes. So I think Metformin is fine. I think the Sulfonylureas are close to gorgeous. And you'll see why it's improved. So when I gave the Lilly lecture in 1987, our understanding of what caused type 2 diabetes was really quite simple. We know that people who are destined to develop this disease inherit a set of genes that make their tissues very, very resistant to insulin. And both the liver and the muscle partake of this insulin resistance. But early in the natural history of the disease, you have a perfectly healthy beta cell. Your beta cell will crank out enough insulin to overcome the insulin resistance in the muscle and the liver. You maintain lower glucose levels. But as this person starts to go through life, who's destined to develop diabetes, what you see is the beta cell can't continually secrete these enormous amounts of insulin. Then as the beta cell starts to fail, the insulin resistance in liver becomes manifest by overproduction of glucose throughout the sleeping hours. So if you have a diabetic patient and they wake up in the morning and their fasting glucose is 160, 170, you have already lost the battle. Because the battle started 12 hours before when the person went to sleep. So we need to have drugs that will work on the liver to suppress hepatic glucose production so the diabetic will start his or her day with a normal fasting glucose. And then when the diabetic patient gets up and they have breakfast and then lunch and dinner, the majority of the carbohydrate in the meal is going to be taken up in the muscle. So muscle insulin resistance in the face of a declining insulin secretory response leads to postprandial hyperglycemia. And in 1987, this was a very straightforward, simplistic understanding of what caused type 2 diabetes. We need drugs that will improve insulin sensitivity. We need drugs that will work on the beta cell. But things have gotten much, much, much more complicated. So there have been two major advances in our understanding of what causes diabetes. The first has to do with the beta cell, and we know that the beta cell failure occurs much earlier in the natural history of the disease, and it's much, much, much more severe than we had previously appreciated. And we've also gained a lot of insight about what drugs will actually work on the beta cell to preserve beta cell function, and you'll probably be surprised when I take you through this as to what really are the best drugs to work on the beta cell. So how do we know this? We know it from two very large studies that we carried out here in San Antonio. Okay, one was called the San Antonio Metabolism Study, or the SAM study. The other is the Vegas study, which stands for Veterans Administration Genetic Epidemiologic Study. So this study is the largest study in the world where we looked at people with prediabetes, impaired glucose tolerance, who were studied by very sophisticated techniques. 259 individuals. You can see over 200 people with type 2 diabetes, and then in green, over 300 control subjects matched to these people. Now, everybody had an oral glucose tolerance test, and during the OGTT, of course, you can look at the glucose level, and that gives you an index of their overall glucose tolerance. Then we measure insulin and C-peptide, and that will give us an indication of how much insulin is secreted. And a separate day, the people come back and they have what's called the euglycemic insulin clamp technique. This is a technique we developed many, many years ago, and this is the gold standard for measuring insulin sensitivity. So basically what we're going to do is we're going to infuse insulin. We're going to raise everybody's plasma insulin concentration by 100 microunits per ml. And then using radiolabeled glucose, we can very precisely quantitate the rates of glucose uptake by all the tissues in the body. And I'm not going to go through the methodology in great detail. I think that little brief overview will suffice. This is the gold standard for measuring insulin sensitivity. Now, on this slide, what I'm going to plot for you on the left panel is the mean glucose area during the OGTT. Then on the right panel, the mean insulin area under the curve during the OGTT. You don't have to worry about the units. What I would like you to do is just follow the heights of the bars. So the first set of yellow bars you see go up here are the values of the people with normal glucose tolerance. And I'm going to put up in a second the people with impaired glucose tolerance. And this is a, quote, pre-diabetic state. So in my opinion, pre-diabetes is like the doctor that tells the lady, you have to touch your pregnancy, okay? You know what happens at 9 months, you deliver a baby, okay? The doctor who tells you you have pre-diabetes, that is really somebody in comedy. You have pre-diabetes, you are going to develop diabetes later in life if you don't take care of yourself. But we don't have any treatment for pre-diabetes, okay? And that's a problem. So impaired glucose tolerance is a type of prediabetes that's diagnosed using the 2-hour glucose during the OGTT. So remember, if your 2-hour glucose gets to 200, you have diabetes. It's 140 or less, you're normal. So we have this very large range of 140 to 199, which is abnormal. So what I'm going to do is I'm going to divide those people into 3 groups. 2-hour glucose 140, 160, 160, 180, 180 to 199. And of course, with worsening glucose tolerance, the area under the curve goes up. But the important information starts over here on the right. So you can see in these people in the first two tertiles of IGT, their beta cell can see the glucose going up, and it also can read that these people are becoming insulin resistant. And it will crank up its secretion of insulin in an attempt to maintain normal glucose tolerance. But it has a finite capacity to do that. At some point, you can already see, long before you develop diabetes, you've tipped over the top of this curve. And the insulin secretory response is already starting to decline. And now, if I add the diabetics, divided into 4 equal groups, you can see that with worsening diabetes, and I've divided them into 4 quartiles equally, as your insulin secretory response starts to decline, your overall glucose tolerance deteriorates quite markedly. And this inverted U-shaped curve, I call Starling's curve of the pancreas, and it's characteristic of beta cell function in all ethnic groups throughout the world, okay? Now, a very, very important point that needs to be made is that measuring insulin levels tells you nothing about beta cell function. So these are two very different concepts, okay? Insulin secretion, how much insulin you can measure in the blood, and the health of the beta cell. If you measure the insulin and you think you're going to get insight, you will be wrong 100% of the time. Okay? Not 50% of the time, 100% of the time. So simply measuring insulin will not tell you anything about beta cell health. This is a major misconception that physicians and even endocrinologists have. Okay? So what is the gold standard for beta cell function? So on this slide, I'm going to plot for you on the x-axis the 2-hour glucose concentration. On the y-axis, I'm going to plot for you the gold standard for beta cell function. So what is the gold standard for beta cell function? Well, first there must be a stimulus. And the stimulus is the increment in glucose above baseline. If the glucose doesn't rise, you're not going to release insulin. Now, in response to the stimulus of glucose, there's an increment in insulin. So a better index of beta cell function would be to look at the increment in insulin or increment in glucose. But in addition, as I told you, the beta cell can read. It knows how insulin resistant the tissues are. If you want, we can talk about how the beta cell knows that later, but it knows. So you have to factor this index by how insulin resistant you are. So the gold standard for beta cell function is the increment in insulin, increment in glucose, all factored by how insulin resistant you are. Now, I'm going to look at this in the individuals who have started first with normal glucose tolerance. I do the OGDT, your 2-hour glucose is less than 140, okay? And I'm going to divide them into 3 equal groups. The first point on the curve are those people, the 2-hour, your glucose goes up and 2 hours later it's less than 100. That's as good as your glucose tolerance is going to get. Well, you can see that these people who have a 2-hour glucose 100, 120, 120, 140, who would be considered to have low glucose tolerance by the American Diabetes Association, they already lost 50% of their beta cell function. And once you take into account the severity of insulin resistance, the beta cell function in the lean and the obese people superimpose. So there's nothing that's unique about the obese diabetic versus the lean diabetic once you account for how insulin resistant they are, okay? And now I'm going to add the people with IGT, again divided into 3 equal tertiles. When you get to the upper tertile of IGT, these people have lost over 80% of their beta cell function. And with the insulin clamp, these people are already maximally insulin resistant. So if I told you I had a person who's maximally insulin resistant and they lost 80% of their beta cell function, and I ask you what's wrong with this person has diabetes, okay? Not according to the ADA definition, but they definitely have diabetes, okay? So in the old days, we knew nothing about pathophysiology, so we based our definition on a phenotype, and the phenotype was proliferative diabetic retinopathy. But by the time you have proliferative diabetic retinopathy, you had your diabetes for 10 years, and you had a lot more hyperglycemia that you were exposed to. So So our cut points for making diabetes are based on these old archaic data, and the disease starts long before that. Now, if I add the people with type 2 diabetes, this person here has a 2-hour glucose of 180, looks pretty good. But they're maximally insulin resistant. They lost 80% of their beta cell function. They lose another 5-10% of their beta cell function, and their 2-hour glucose is now 360. Okay? So you go from this stage to this stage with very, very little additional insight. And that's something that people do not understand. So when you were in the pre-diabetic state, you were very close to becoming severely hyperglycemic, and then going from a range of A1C, where you probably are not going to develop the microvascular complications, to a range of A1C where you're going to be at very high risk for the microvascular complications. Now, in everyday life, things don't happen in absolute terms. Biomedical phenomena usually occur as a log function. So on this slide, what I've done is taken the log of the data from the previous slide. So this is the log of the 2-hour glucose concentration, and this is the log of that index of beta cell function. And when you do that, what you see is you now have a perfectly straight line with an R value that you almost never see anything like this in any kind of human disease, okay? You see this in mice. Why? Because they're all inbred, you know, you can do whatever you want to them, you treat them the same way. People are not like that. We have much more divergent background, and this kind of correlation coefficient is really amazing for human type disease. So here are the NGT, here are the IGT, here are the diabetic. Now, if I were a magician and I could just take the color off of that slide, it actually turns out I am a magician. Okay? Now I ask you, here it is. Who are the people with diabetes? Who are the people with IGT? Where are you going to put the cut points? Okay? There's no way you would know where to put the cut points. Okay? You don't all of a sudden go from normal glucose tolerance to diabetes. This is a continuum. Okay? It also means that the earlier you treat, the better off you're going to be. Now, you can argue when you should start to treat, but the fact is, earlier is better. How much earlier? Well, we can debate that. And it also says, once you're maximally insulin resistant, what determines whether you develop diabetes is what happens to your beta cells, okay? So we need drugs that will work both to improve insulin sensitivity and both to improve beta cell function. So people with IGT are maximally or near maximally insulin resistant. They've lost about 80% of their beta cell function. I will show you how to get back the beta cell function. That I can do. Here's the big problem. The longer you wait to treat, they lose beta cell mass. And there's no drug that I am aware of that will regenerate beta cells. It's a big interest of ours. Actually, we think we can do it. If you're a mouse or a rat, I can cure your diabetes and regenerate beta cells. We have a patent on this methodology. But whether this will work in humans or not remains to be seen. Moreover, you can see that the complications start long before you develop diabetes. So if you are, quote, pre-diabetic in this IGT state, 10% of the people already have background diabetic retinopathy. 15% have microalbuminuria, which is the precursor, which is going to go on to develop diabetic nephropathy. And another 15% have peripheral neuropathy. So the microvascular complications are starting at a very early stage. Of course, they're not severe. You don't have proliferative diabetic retinopathy, but you have to start someplace, okay? So IGT or prediabetes is not an innocuous disease. And if I look in your eye grounds and I see microaneurysms and hemorrhages and exudates, you have diabetes, and I don't really care what your glucose level is or your A1C. And I would start to treat that person, even if their A1C was 6.2 and their 2-hour glucose was 175. They're already getting end organ damage, and then sometimes you have to use drugs off-label that are not approved for the treatment of prediabetes, because we don't have any drugs for treatment of prediabetes. So the implications are pretty obvious, okay? We need to start early at the stage of IGT or IFG, but of course there are no drugs approved by the FDA to treat early on. And when we start picking drugs, the drugs should correct the underlying pathophysiologic disturbances. Okay? Now, the next major breakthrough in the last decade has to do with the complexity of the disease. Okay? So when I gave the Banting lecture in 2008, the Banting lecture was titled From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So the disease is much, much, much more complicated than we previously imagined. So the core defects, insulin resistance in liver, insulin resistance in muscle, and the beta cell failure, they're still here. But now we have a whole bunch of other defects that we have to deal with. So starting in the upper right, the fat cell. When you eat, you take in excess calories, you put them into the fat cell, and you store them as triglycerides. As long as the fat stays there, it can't hurt you. But it turns out, when you start to gain weight, or in a diabetic, even if you're lean, your fat cells are resistant to insulin. Insulin is the brake. It's the anti-lipolytic hormone. So now when your fat cells become resistant to insulin, you break down the triglyceride, you release the FFA into the bloodstream, and what happens? Elevated FFA causes insulin resistance in muscle and liver. Elevated FFA poison your beta cells. And on a long-term basis, elevated FFA kill your beta cells, okay? So FFA are a very important part of the pathophysiology of the disease, okay? The top, the gut. The gut is a giant endocrine organ, and it secretes two incretin hormones, GLP-1, glucagon-like peptide 1, and GIP, gastric inhibitory polypeptide. So when you eat a meal, you release these two hormones, and we're going to come back and talk about them in more detail because they're very, very important from the therapeutic standpoint. And these two hormones together account for 70% of the insulin which you release in response to a meal. If I knock out either of those hormones in anybody's body in this room, I guarantee you I make you diabetic, okay? So these are not trivial hormones, okay? Every day you eat 3 times a day, the only reason why you maintain normal glucose tolerance is you release those two hormones. Now, what goes wrong in the diabetic? Okay, it turns out there is a problem with the beta cell's ability to respond to the GLP-1 and GIP. There's severe, severe, severe resistance to these two hormones. What about the circulating levels of GLP-1 and GIP? They're basically normal. So if you look at all the studies, some studies show a little bit of an increase, a little bit of a decrease, normal. But on mean, there's no major change in the plasma level of GLP-1 and GIP. The big problem is the beta cell is resistant to GLP-1 and to GIP. And we'll come back to this because we have a therapy for this. In the upper 9 o'clock here, we have the alpha cell. Now, we've known for many, many years that diabetics have elevated fasting glucagon levels, and the glucagon levels don't suppress normally during a meal. So these elevated glucagon levels drive hepatic glucose production. In addition, studies that we did many years ago, we showed that the liver is hypersensitive to glucagon. So now you think about this. You go to sleep at night. Your brain has an obvious need for glucose. Where does that glucose come from? It comes from the liver. So what's regulating glucose production from the liver? It's insulin and glucagon. You have a liver that's resistant to insulin. Number 2, you don't have any insulin. Number 3, you have a liver that's hypersensitive to glucagon. And 4, you have too much glucagon. These 4 abnormalities conspire to drive hepatic glucose production throughout the sleeping hours, and that's the major cause of fasting hypoglycemia. So in the treatment of the diabetic, you've got to knock down the glucagon, and of course you need to augment the insulin. And if you do that successfully, you'll suppress hepatic glucose production. And then the diabetic, when they wake up and start their day, will start with a fasting glucose of 100. Okay? The kidney. The kidney also plays a critical role in the pathophysiology of the disease. So if you become diabetic, some strange things and very paradoxical things happen at the level of the kidney. So in you or I, our threshold for spilling glucose into the urine is about 180. So if I plug in an IV and I start infusing glucose and I raise your glucose from 80 to 100, 120, 150 to 180, zero glucose appears in the urine till I get to 180. Above 180, okay, I've now exceeded the threshold and the maximum reabsorption capacity. The kidney dumps all of the glucose into the urine. Okay? What goes wrong in the diabetic? You get to 180, no glucose. You get to 200, no glucose. You get to 220, no glucose. Okay? The threshold has increased markedly. It's a whole new physiology. You can't read about it in any textbook. You can only read about it in the papers that we just described. And it's only in the last year that this has all become very clear. So if you have a hemoglobin A1C that's 6.5, which you'd probably love to have in your patients, the threshold at the level of the kidney, which is no glucose, has already gone from 180 to 205. If you have an A1C that's 7.5 to 8, the threshold has gone from 205 to 220 to 230. If you have an A1C that's 9, the threshold for spilling glucose in the urine is 240 to 250. So if you think about this, remember in the old days, we used to measure urine glucose in 3 patients. Well, first, the urine glucose is way behind the blood glucose, and virtually no glucose is appearing in the urine. That's why we never got anybody under control in the old days. And as you'll see, we have drugs that will block the reabsorption of glucose. Now, this defect cannot start the disease, but once your blood sugar level goes up, it now plays a very, very important role in maintaining the high blood sugar level. And then we also know that the brain has become resistant to insulin and a whole host of other neural peptides and other hormones. So Dr. Daniel Port showed many, many years ago, if you take a normal healthy individual and you just give them 1 to 2 units of insulin, enough to get a modest increase in the insulin level, but not enough to lower your glucose, you turn off the appetite completely. Well, if you look at people who are overweight, they're all insulin resistant, they're all hyperinsulinic. Do they stop eating? And the answer is no. Okay? Your brain has become resistant to insulin. What else does your body secrete that shuts off your appetite? Insulin is secreted in 1-to-1 ratio with insulin. Your brain is resistant to insulin. PYY, the most powerful anorectic hormone in the human body. Your brain is very resistant to it. GLP-1, which comes out every time you eat a meal, a powerful anorectic hormone. Your body is resistant to it. When your fat cells expand, they release leptin. Your brain is resistant to it. There are a whole host of other abnormalities that I can take you through. This is why 90% of people, 48 large prospective studies, 90% of people, they're good at losing weight during the study. 1 year after the study, they have gained back virtually all of the weight. Okay? Your brain cannot overcome all of these physiologic disturbances. You may think you can, you will fail on a long-term basis. Okay? 48 studies, 48 failures as the person comes out of the study. So those of us in the diabetes obesity field now believe that in addition to behavioral modification, you are going to need some kind of medication to go with the behavioral modification to really make a major impact in getting people to lose weight. So let's take these 2 slides. So when you think about it, this is a very complicated disease, okay? And you are going to need multiple drugs to correct all of those 8 pathophysiologic disturbances. There's no one magical drug that's going to do it. So you really need to understand the pathophysiology, and then you need to choose drugs that correct the problem. If you simply give drugs that lower the A1C, but don't correct the problem, you're going to fail. And then you need to start early, before things really deteriorate and you start losing beta cells, okay? Now, what I'm going to do is to take 4 of the major disturbances, and then I'm going to take you through the drugs that will correct the disturbances, all right? And I think you'll be probably somewhat shocked by what you're going to hear, because my guess is there are major misconceptions in this room about what drugs work and how they work. So we'll start at the level of the liver. So there are 2 good drugs that work on the liver, okay? One is metformin, and the other are the thiazolidinediones. For all practical purposes, people use it. They work through two different mechanisms. Metformin, we still don't know how it works. We can come back to that if you want later on. The TZDs work through the PPAR system. But they both work on the liver to suppress hepatic glucose production. So this combination is part of the triple therapy that we use as the Texas Diabetes Institute in all newly diagnosed patients. So I said triple therapy. So there's still one more drug for you to find out about, okay? But because these two drugs don't increase insulin secretion, no hypoglycemia. Because they work through different mechanisms, you get a completely additive effect. At the level of the muscle, we have two drugs. In my opinion, we have only one drug, okay? So if I were to ask clinical endocrinologists, is metformin an insulin sensitizer in the liver, 90% of people would say yes, and 90% of people would be absolutely wrong, okay? So metformin is not a direct insulin sensitizing drug in the muscle. The TZDs are. So why the confusion about metformin? The entire drug development for metformin in the United States was done by myself. There was no other doctor involved other than Dr. Jerry Daniels, who came from Buffalo in France. And as part of the submission to the FDA, we did this insulin clamp technique to measure insulin sensitivity. And what we found was that there was a bimodal distribution. There were some people who actually got an improvement in insulin sensitivity, and the majority of people didn't. So what was the common denominator? So it turns out that metformin is a very anorectic molecule, and it causes a lot of GI disturbances. So the average weight loss with metformin at the end of 6 months is about 2.5 kilos. If you lose weight, you get an improvement in insulin sensitivity. If you do not lose weight, there is no improvement in insulin sensitivity. So in a certain way, yes, metformin does improve insulin sensitivity, but it's not a direct insulin sensitizer in terms of the TZDs are, where the TZDs bind to a receptor, the PPAR receptor in muscle, and they institute a whole host of changes that improve insulin sensitivity, okay? So the only true sensitizer in muscle are the TZDs. Then at the top, what works at the fat cell to improve insulin sensitivity? Only the TZDs. They enhance the ability of insulin to suppress lipolysis. The plasma FFA level comes down. When the plasma FFA level comes down, you improve insulin sensitivity in muscle, in liver, and you improve beta cell function. At the top, the beta cell. Now this is more complicated and more controversial. So you may be surprised that the #1 drug that I put at the top of the list are the thiazolidinediones, because you think the TZDs have their major effect to improve insulin sensitivity. Well, they do have a big effect here, but they have an even bigger effect to improve and preserve beta cell function. And as I will show you, the reason why these drugs work, and they work on a long-term basis, is because they have a big effect on the beta cell. And they also improve insulin sensitivity, okay? Now, TZDs actually are very good drugs to be used in people with impaired renal function. They're really quite safe in this group of people. Metformin, of course, you cannot use, because if you have impaired renal function, your creatinine is up. You're not supposed to use this class of drugs. Next on the list, after the TZDs, are the GLP-1 receptor agonists. This class of drugs is pretty close to the TZDs in terms of their effect on the beta cell. And the only difference is that we have many, many more studies with the TZDs than we do with the GLP-1 receptor agonists. But I will show you the studies with the GLP-1 receptor agonists. Although we have fewer studies, the studies are so well done with such sophisticated technology. This is the other class of drugs that has a big effect on the beta cell. And this is the third part of triple therapy for all newly diagnosed diabetic patients. And moreover, this is another class of drugs which can be used very effectively in people with impaired renal function. And then DPP-4 inhibitors are close to worthless drugs, okay? Merck sold you all a bill of goods, okay? These drugs are the weakest drugs on the market, okay? you pay $250 a month for a drug that does almost nothing. The problem is that the beta cell is resistant to circulating GLP-1. What does a DPP-4 inhibitor do? Does it increase the level of GLP-1? Absolutely not. Your beta cells, if you're a diabetic, have failed when given GLP-1 level. All the DPP-4 inhibitor does is keeps that GLP-1 level around longer. That ain't gonna help your beta cell. And that is why every study that has looked at the effect of the DPP-4 inhibitors after year 1, without exception, shows that these drugs fail. These drugs are the safest drugs in the world. That's the beauty of them, okay? They're very gentle. So if you have a high-risk patient for cardiovascular disease and you want to drop in the A1C of 0.6 and you don't have to worry about hypoglycemia side effects, it's a very nice class of drugs, okay? If you have a newly diagnosed diabetic patient who has an A1C of 8.5, and you want to get the A1C down, and you want to keep this person controlled and save their beta cell, this is probably the worst class of drugs that you can use. Not quite. It's the worst class of the sulfonylureas, okay? So, the last time I used a sulfonylurea drug in a patient of mine was 1990. Okay? I intend to die, maybe 30 years from now, maybe 40, I don't know. But I will never prescribe a sulfonylurea drug for a patient. Okay? These drugs, 22 out of 22 long-term studies, okay, show failure after the first year. These drugs bind the sulfonylurea receptor. They kick out insulin. The insulin suppresses hepatic glucose production, overcomes the insulin resistance in muscle during the first year. Your beta cells are still dying, even though you lowered the A1C. And most people don't appreciate this, okay, including endocrinologists. Then after year 1, then you see the A1C rising. So this is a class of drugs, has no effect on insulin sensitivity, and there's a lot of literature that suggests that this class of drugs actually may accelerate the rate of beta cell failure, and there's a lot of controversy as to whether this class of drugs actually promotes atherogenesis. Remember, this is the only class of drugs that has a black box label on it that says if you use these drugs, you may have a heart attack, stroke, and die. Most of you probably not even aware of that, because you had some old professor who taught you it and never, well, maybe he had Alzheimer's disease and he didn't have his memory bank, and so he didn't pass it on to you, okay? So what's the number 1-2 punch in the United States? Metformin, and when you fail, and you will, you add a sulfonylurea. And what's the ADA algorithm? After you fail on the sulfonylurea, and you will, you add insulin. So what is this algorithm? This is the economic algorithm. You have to understand that. Okay? Metformin, $4 a month. Sulfonylurea is $4 a month. Okay? Insurance companies love you. You need to understand that HMOs and insurance companies, and this may sound very harsh, they do not care about the patient. And I don't care what they say. The only thing that they care about is the bottom line. They have stockholders and they have to turn a profit. And therefore, they are going to use the least expensive drugs. They are not going to go to the more expensive drugs that work. So you're going to have to fail on metformin and SUs. And the problem with that is the longer you wait to come in with the newer drugs, which will work, the more you lose beta cells, the more difficult it becomes now to treat the patient. So I'm going to use the United Kingdom prospective diabetes study to illustrate these points for 2 reasons. Number 1, I had nothing to do with the United Kingdom prospective diabetes study. And number 2, this is a long-term study. It's the only long-term study that we have, looking at what drugs do glycemic control. So here's time, and on the y-axis, the A1C. Now, Dr. Robert Turner, when he started this study, really believed that if you put someone on a single oral agent, the A1C would come down, and it would stay down for the rest of your life. So he started these studies some 30 years ago. One group, there were 4,200 people in this study, was told to lose weight and exercise. You can see in yellow, this was about as effective in the United Kingdom as it is in the United States, okay? It doesn't work the way we normally do it, okay? glyvancomide in green, that's glyburide, okay? It kicks out insulin, overcomes the insulin resistance, the A1C falls, then you can see it gradually starts to rise. Metformin is the yellow, orange curve. It suppresses hepatic glucose production, but it doesn't have any effect on the beta cell. Fasting glucose comes down, A1C comes down, and then progressive rise, okay? Here, at 5 years, the A1C is back to when you started or above. Dr. Turner wrote 5 articles: diabetes, diabetes cure, diabetologia, BMJ, Lancet. These are not obscure journals in the diabetes field, but it looks like most endocrinologists have made them obscure, okay? And HMOs have burnt them because they don't want to see what's there or what Dr. Turner said. What Dr. Turner said is, I have to change the study design of UKPDS because my hypothesis is not correct. You cannot put someone on a single oral agent, have the A1C come down and stay down. So here at 5 years, if you're on glyvancomide, you add a metformin. If you're on metformin, you add a glyvancomide. And then if that didn't work, you add an insulin. At the end of 15 years, the A1C is 8.6, and 65% of the people are on insulin. This is evidence-based medicine, okay? How many people in this room, if I told you I had this wonderful therapy, and that 10 or 15 years later, you're gonna have an A1C of 8.6, and you had a 65% chance of being on insulin, how many people in this room want that therapy? Raise your hands. Yeah, you have to be a complete fool to want that. But if I come and look at your charts, that's what most of your patients are on, okay? You're forced to do it. You don't really have much choice from the economical standpoint. Now, this was the very first study to show that improved glycemic control decreased the microvascular complications. So in the diabetes field, this is a landmark study. So this difference between the conventional and treatment group decreased eye, kidney, and nerve complications by 37%. So how do you view this study, okay? So this is a fine glass of Barolo wine, okay? Came from my wine cellar. So that glass is half empty and it's half full. So what part of the glass do you like, okay? Well, I happen to like that part of the glass, okay? That's the 37% decrease in eye, kidney, and nerve complications, okay? This is the part of the glass I don't like. That's, you're gonna end up with an A1C of 8.6 and you have a 65% chance of being on insulin. So these are the data. And different people will look at this in different ways. This happens in science all the time. The results are the results. One person says, oh, this is what it means. Another person looks at it and says, no, this is what it means. So the American Diabetes Association says, oh, this is the only study that we have showing that we decrease eye, kidney, and nerve complications, as do HMOs. Therefore, we're going to use metformin, followed by SUs, going to follow by insulin. I look at it and say, yeah, that's pretty good, but this is pretty horrific, okay? So I would choose something else. So it kind of depends on how you want to look at this study. You have all seen the data. Now, you can make up your own mind as to what you think about it. So wouldn't it be nice if what Dr. Turner really wanted was you drop the A1C to 6? And if you did that, look at the excess glycemic burden you get rid of. No one would be developing the microvascular complications. That's, I think, what we would all like, okay? And in fact, you can do it. So, if you go through the literature, when I gave the Banting lecture, these were the 10 studies that were in the literature with SUs. There are now 22. They all show exactly the same thing. So, whether it's glimepiride, glyburide, glycoside, which we don't have, there's an initial drop in the A1C with all of these, the spaghetti plot. And then you see they all go up. There are no exceptions. There are another 12 studies that I could add. Now, what about metformin? Metformin does the same thing. So this is a study from Kaiser Permanente with long-term follow-up, 6 years, in which we're going to plot the percentage of individuals who have an A1C greater than 7.5. Okay, remember, the treatment goal for ACE, American Association of Clinical Endocrinology, is an A1C of 6.5. The ADA goal is 7. So they bent over backwards, said, we're gonna call failure 7.5, okay? I put you on metformin in the first 3 months, okay? And now, what happens to your A1C? Meaning you fail, okay? At the end of 5 years, 60% of the people fail. This rate of decline is exactly what's happened in UKPDS. Now, the longer you wait to treat, so here you wait, treat between months 4 and 11, here you wait, treat the second year and the third year, the worse off you are. Why? The longer you wait, the more beta cells die, the less all drugs work, okay? So, you think metformin, and I developed this drug. I like metformin. But the fact is, realistically, this drug does not have an effect on the beta cell. And if you don't save the beta cell decline, you're gonna run into problems, okay? Now here are TZDs. TZDs are actually drugs that can be used very effectively in your renal failure patients. So, Thiazolidinediones, rosiglitazone. The initial decline is different, okay? So, for instance, in this study, the people who were on metformin, I took the metformin away and I added thiazolidinediones. In this study, the people who were on metformin, I kept them on the metformin and I just added the thiazolidinediones. The point I want to make is that whatever the initial decline is, what you see is it stays down. And in the DOC study here with rosiglitazone, 5 years, okay? Much, much better than what I showed you with metformin or sulfonylurea drugs. And the reason why the TZDs work so well is they have a huge effect to improve insulin sensitivity, and they have a huge effect to improve beta cell function, okay? So the insulin sensitizing effect has been around forever and ever. Many people, including ourselves, demonstrated this for some 15 years. But what was not well appreciated, but was very clear to us, is this class of drugs must have a big effect on the beta cell. So we did a study, the results are shown here. We're gonna look at this index of beta cell function. This is insulin secretory rate divided by the rise in glucose, all factored by how insulin resistant you are. In drug-naive patients, I had placebo, nothing happens. I had thiazolidinediones or rosiglitazone that caused a 2.5 to 3-fold increase in beta cell function. This has been published for a long time. Most people are not aware of this. If you had your disease for 10, 12 years, we want to know, will the drug work? So we took people who were on SUs, and at placebo, nothing happened. You had thiazolidinediones, big improvement in beta cell function. So this class of drugs not only is a powerful insulin sensitizing class of drugs, but it also improves beta cell function, okay? Now, you may be concerned about the issue of bladder cancer, because this is what's killed thiazolidinediones. So the FDA asked Kaiser Permanente, the FDA asked Takeda to do a 10-year follow-up study. It was done at Kaiser Permanente. The 10-year data we just announced, it's going to be in January. The hazard ratio for bladder cancer is 0.98. In Diabetologia this month, there's a very large review from 6 different countries, 6 major databases throughout the world, 1.1 million people treated with either thiazolidinediones or rosiglitazone. Hazard ratio for bladder cancer, 1.00. So this scare about bladder cancer, which has killed thiazolidinediones, is really a hoax. The drug has been crippled to a large part because of the lawyers who got involved. Now, GLP-1 receptor agonist, okay? So in response to oral glucose, you always release a lot more insulin than if I were to give you the glucose intravenously. And the 2 hormones that are responsible for this are glucagon-like peptide 1, GLP-1, and glucose-dependent insulin-trophic polypeptide, GIP. Now, these 2 hormones account for 90% of the incretin effect, and they account for 60 to 70% of the insulin that you secrete in response to a meal. So where do these hormones come from? So GIP comes from the K cells that are in the early part of the duodenum, and GLP-1 comes from the L cells, or way down in the distal part of the small bowel, large bowel. Both GLP-1 and GIP release insulin. GLP-1 inhibits glucagon, GIP has no effect, okay? GLP-1 shuts off your appetite when you lose weight. GLP-1 slows gastric emptying. GIP doesn't do either the appetite suppressant effect or slow gastric emptying. So this gastric emptying effect is very important. Newly diagnosed diabetics have a markedly accelerated rate of gastric emptying. So that means they're going to absorb the glucose more quickly. And their beta cells can't get the insulin fast enough. So it's good to slow down gastric emptying. It's not good to give this class of drugs or give GLP-1 to someone who has 10 years of diabetes with gastroparesis, okay? In addition, GLP-1 has a number of beneficial effects on the cardiovascular system, which I'm not going to talk about. But because GLP-1 increases insulin, inhibits glucagon, makes you lose weight, delays gastric emptying, and has these effects, this is the hormone that was developed as a therapy for the treatment of type 2 diabetes. And as I said, this is the third part of triple therapy. So, I told you earlier that the problem with GLP-1 in the human body in diabetics was resistance to GLP-1. So we're going to infuse GLP-1 into control subjects in yellow and in diabetics in orange. Then we're going to measure how much insulin comes out. So I'm infusing the GLP-1, and as GLP-1 goes up, you can see up goes the insulin. And this rise in GLP-1 is about what would happen after a meal if you were eating next meal. When you do it in the diabetics, you see they don't release any insulin. So now I'm going to take these diabetics back, and I'm going to double the infusion of GLP-1, and I'm going to raise the level to 100 picomolar or above. This is the kind of level that you get with the drugs that I'm going to tell you about in a second. And now look what happens. You have a normal beta cell, okay? In my opinion, this with pioglitazone are the two best drugs for the treatment of people with type 2 diabetes. And these two classes of drugs are absolutely safe to be used in people with impaired renal function, okay? So we have 5 of them. The first one was exenatide. This is short-acting. It's given twice a day with meals. Should really be given 3 times a day because it's very short-acting. This is exenatide once weekly. This is by Dorian, okay? This is liraglutide, the novo drug. It's Victoza. This is Tanzine, albiglutide. This drug I don't recommend. It doesn't work very well. It's 2 GLP molecules stuck on albumin, so it's a very large molecule. It doesn't cross the blood-brain barrier, so almost no weight loss, and the drops in A1C are far inferior, okay? What's the best thing about this drug? Of course, if you have a drug that doesn't work, what are you gonna do? They give it away free. And that's true. So you can get this free for everybody, okay? Because it's so ineffective and they clearly cannot compete with the rest of the world. This is Trulicity. This is dulaglutide, very good once weekly. So a lot of competition in this field and more to come. So these drugs effectively lower the A1C. They preserve beta cell function. They promote weight loss. They correct known pathophysiologic defects in type 2. They don't cause hyperglycemia, and they have a good safety record. So I actually directed the entire GLP-1 program in the United States. And this is a composite now of all of the data with Byetta that went to the FDA. And all the studies were designed the same way. So you go on placebo, 30 weeks, nothing happens to your A1C. You go on the exenatide, nice drop of 1 to 1.2. At 30 weeks, the people on placebo get switched to exenatide, A1C comes down. The people on exenatide stay on it, and now we have the 3.5-year data. If I didn't tell you anything else, and I asked you, why did the A1C come down and stay there? The only thing that will do that is if you have a powerful effect on the beta cell. You don't even have to measure beta cell function. It's the only way that that can happen. So, in fact, beta cell function has been measured. This is a very, very famous study in the diabetes field. So it's by Doctors Bunk and Heine. And what they did is they took 59 type 2 diabetics who were inadequately controlled on metformin. And then half the people went on exenatide, the other half the people went on large. So why is glargine the control? So they want to know what is the effect of exenatide on the beta cell. So I'm going to give you a drug, and it's going to have an effect on the beta cell, and it's going to kick out insulin, it's going to lower your glucose. When I lower your glucose, and we'll come back to this again with the SGLT2 inhibitors, there's a very important pathophysiologic concept that's related to glucotoxicity. High glucose poisons your beta cell, okay? So I have to have a control for lowering glucose with a drug that doesn't affect the beta cell directly, and that drug is insulin. So this is the control for lowering glucose. This is the drug that's going to lower glucose and have a direct effect on the beta cell, and the difference will tell me what the exenatide is doing, okay? And then what we're going to do at baseline, at 1 year, we're going to do what we call a hypoglycemia, another technique that we developed. We're going to raise the glucose here by 15 millimolar, and we're going to clamp it at 15 millimolar above baseline. When you do that, there's an acute phase of insulin in the first 10 minutes, followed by a gradually increasing phase of insulin, okay? I'm going to show you the 1 year data. This study went on for 3 years. There was a repeat study at 3 years, identical to what I'm going to show you, okay? So here's the hyperglycemic clamp. I raise the glucose, I clamp the glucose at 15 millimolar. So the orange curve is first phase, which is lost in diabetic, comes back a little bit to correction. It's completely normalized with the exenatide. Second phase insulin secretion here, completely normalized with the exenatide, efficient with the larger. Now, this is at 1 year, but they had a baseline study. Okay, so I'm going to pop up some inserts. I know how much insulin came out at 1 year. I know how much insulin came out at baseline. I'm going to look at the ratio. Okay, how much of an increase in insulin secretion occurred at 1 year compared to baseline? So with glargine, the ratio is 1.31. That meant that there's a 31% improvement in insulin secretion. That's the effect of glucotoxicity. Simply lowering the glucose improved beta cell function by 31%. Okay? This is with exenatide. That ratio is 3.19. There's a 319% improvement in beta cell function. And in fact, this curve is normal. You have a normal beta cell at 1 year. You have a normal beta cell at 3 years. There is nothing in the world that will do it other than this class of drugs, okay? Now, the next slide is, in my opinion, the most important study that's been carried out in the last 20 years in the diabetes field. And again, it's amazing to me how few people in the diabetes field even know this study. So there's another way in which you can assess beta cell function. It's called the graded glucose infusion of Polanski, Ken Polanski's head for dean at the University of Chicago. So what we're going to do is we're going to infuse glucose, we're going to raise your glucose, and then we're going to measure your insulin secretory rate using deconvolution C-peptide. And as you raise glucose, you see there's a continuous increase in insulin secretion as a function of the rise of glucose in these normal glucose tolerant individuals. What happens in diabetics? The diabetic beta cell is blind to glucose. Now I'm going to take these diabetics back and I'm going to restudy them. And I'm going to give them 1 dose of liraglutide, 7.5 micrograms per kilogram. So a thin patient at the Texas Diabetes Institute would weigh 100 kilos. That's a lean one, okay? So I'm going to move 100 times 7.5 micrograms per kilogram, that's 0.75 milligrams. What is the starting dose of this drug? 0.6. And then what do? You go to 1.2. And then what do? You go to 1.8. So basically in this study, they're giving the starting dose. It's not even the therapeutic dose, okay? And I'm going to give it 8 hours before I repeat the study. 8 hours before. And now you are going to see a mirror. You have a normal beta cell in 8 hours. There is nothing in the world that will do that. Nothing. You go from being a sick person with a high glucose in a beta cell that does not work, and in 8 hours you have a normal beta cell. And from the Bunkenheine study, this effect lasts for 3 years. This class of drugs should be number 1 at the top of your list for treatment. So why is it that this class of drugs has only 3% of the market in the US? One, it's an injection, and docs don't like injections, particularly primary care docs. And number 2, it costs $250 to $300 a month. So it's very difficult to get this drug unless you fail on Metformin, Sulfonylureas, and other drugs, okay? But it's very, very effective. And this class of drugs is the third part of triple therapy, and I actually really don't care which one you pick, okay? I'm on the advisory board for all of these companies, and I lay them out for my patients. There's some small differences between them, and I tell them, you'll pick one of these, and if you choose to pick another one, none of them, just go find another doctor, and don't come back. And that's what I tell them. And you know how many people don't come back? 0, okay? So the way you present things to the patient and your confidence and understanding of what goes on will in large part determine whether the patient works with you, okay? But this class of drugs really works. Now, here's sitagliptin, DPP-4 inhibitor. Here's liraglutide, Victoza, 1.2 milligram, and then the higher dose, 1.8. You can see that this GLP-1 receptor agonist is far superior to the DPP-4 inhibitor. Why? The DPP-4 inhibitor doesn't increase your GLP-1 level. It just keeps a level that's not working around longer. What does this do? This increases markedly your GLP-1 level. It overcomes the beta cell resistance, and therefore you crank out more insulin, and you will inhibit glucagon. Another benefit. And you lose weight, which will improve insulin sensitivity, and you delay gastric emptying. And there are probably some cardiovascular benefits that go with it as well. Now, the most recent class of drugs, the SGLT2 inhibitors, and at the level of the kidney, you filter about 180 grams of glucose every day. In the early part of the proximal tubule, there's a receptor called SGLT2. S is for sodium, GL is for glucose, T is for transporter, 2. That transporter takes back 90% of the glucose. If it does its job, there's another transporter distant to that, SGLT1. It takes back the remaining 10%, and you're right, no glucose appears in the urine. I've already told you in diabetics, the reabsorptive capacity of the kidney and the threshold are markedly increased. Well, there's a whole new class of drugs that's developed, the SGLT2 inhibitors, and they block glucose reabsorption in the kidney. So, in my lifetime, I have only done one stupid thing that I will admit to anyone. And that is, I developed this class of drugs with fluorescein, and I never patented this. I just went ahead and published it. And that was a mistake. And now, we have 3 of them. And this is the fastest selling class of drugs in the United States in terms of the clinical. Dapagliflozin, this is Farxiga, enagliflozin, Incretin, empagliflozin, Jardiance. And if you're in Japan, there are a whole bunch of other ones, but they're not coming to the US market because they cannot compete. So these drugs are very, very effective. They work on the kidney. So it really doesn't make any difference whether you have no beta cells at all. You could be a type 1 patient, you'll respond. You could be severely insulin resistant, you'll respond, okay? And this is now just a brief run through. So as monotherapy, add on to Metformin, add on to SU, add on to Thiazolidinediones, or insulin, okay? The drug here is dapagliflozin, Farxiga. It comes at 5 milligrams or 10 milligrams. Then the third column is efficacy. But if you just read across, 0.8, 0.91, it drops to about 0.8, 0.9, starting with A1Cs of about 8. So these drugs are quite effective, and they can be used in anybody. You can use them as monotherapy. You can add them on to Metformin, SU, Thiazolidinediones. If you're on combination oral therapy, you can add them on. If you're on triple oral agents, you can add this class of drugs. If you're on insulin, you can add this class of drugs. The studies are going on in type 1s. It works, and I'm pretty sure within the next 6 months we'll have approval to use it in type 1s. I think these drugs will work very effectively at the pre-diabetic stage. We have some studies that are looking at this thing. Now, in summary then, if I had to pick a regimen okay, that's going to work, okay? The regimen I would choose is, of course, lifestyle is the basis of all regimens, that goes without saying. But you need to have some pharmacological help. So we use triple combination therapy in newly diagnosed patients, PO and Metformin. These are the insulin sensitizing drugs. They don't cause hypoglycemia. You get a completely additive effect. Metformin partially blocks any of the weight gain that goes with PO. GLP-1 receptor agonist, wow, okay? It can be used with this combination. Does not cause hypoglycemia. These drugs don't cause hypoglycemia. You put GLP-1 with phenylglycerin, you lose all of the weight that you would get with GLP-1. You never gain weight, okay? They save your beta cells just as phenylglycerin saves your beta cells. They work by different mechanisms. And in fact, if you want to read about this, this month in diabetes, obesity, and metabolism, we had a very large grant funded by the ADA to compare the ADA algorithm, which is you start with metformin, and when you fail, you add an SU, and when you fail, you add basal insulin compared to this. The 3-year data are published in Diabetes, Obesity, and Metabolism. It doesn't make any difference what you want to look at. It's total destruction of the ADA algorithm. At 3 years, there's already a difference of 1% in the A1C in favor of the triple therapy algorithm. There's 7 kilogram weight difference between the two drugs. 3.5 kilograms of weight gain with the ADA algorithm, 3.5 kilograms of weight loss with the triple therapy algorithm. Hypoglycemia, 3 years later, okay, starting with an average A1C of 8.8, the A1C with the triple therapy algorithm is 5.8. With the ADA algorithm, it's 6.9. Hypoglycemia is 7.5-fold greater with the ADA algorithm. Their A1C is 6.9, our A1C is 5.8. Beta cell function with our algorithm is completely normal 3 years later. With the ADA algorithm, you lost 92% of your beta cell function. Insulin resistance, you are maximally insulin resistant with the ADA algorithm. There's no effect whatsoever. There's a 50% improvement in insulin sensitivity. And in fact, this grant, which has been going on for 3 years, I just submitted it to the ADA and to the NIH, and it was funded by both organizations to go on for another 3 years. So I have to choose which one I'm going to pick. So someone was impressed by the data. So there is a real now life study looking at the ADA algorithm versus this approach, and it works. And our goal in this study was to get the A1C less than 6. And the people are there. They're at 5.8 3 years later. So we took everybody, A1C 6.6 up to 14.4. 25% of the people with an A1C above 10, every one of those people has an A1C less than 6 now, 3 years later. So we know that it works. So we'll see. Endocrinologists will understand this. The HMOs, they're going to just trash it, okay? Because they don't want this approach. Importantly, phenylglycerin is generic now, so it's not very expensive. Metformin is generic. So we have only one expensive drug that we have to deal with. That's the GLP-1. So that's the last slide that I was going to show. And I'm more than happy to answer any questions that you might have about anything I've said or the specific implications of this for the patients with impaired renal function. Yes.
So, my name's Connie, and I'm one of the transplant surgeons here. So, my perception, which could be totally wrong, is that in terms of labeling patients as type 1 or type 2 diabetics, very rarely would anybody be measuring insulin resistance or insulin secretion. It's more based on the age of the patient, the diagnosis, or what medication they may already be on. I guess I'm curious what you think would be the appropriate way to handle that labeling, and if you think there are, who are the type 2 diabetics that benefit from insulin, and maybe specifically pancreas transplant?
Yeah. So, when you make the diagnosis of type 2 diabetes, by definition, you are maximally insulin resistant. You don't have to measure it. When you lost a piece of